certainly one setting where kind of the online format, tends to work pretty well, assuming everybody can get logged in and everything. And I can't remember exactly how the question and answer part works with the questions, but if there's a question, feel free to interrupt or put that in right away. I can try to address those as we go. But no, thank you everybody for joining. I appreciate that. So first part of the talk is about men's health, specifically looking at erectile dysfunction. We'll talk about some definitions, treatment options, and kind of really what the breadth of erectile dysfunction includes. In today's environment, that can mean a lot of different things to different people. Many people are sort of familiar with the idea of lifespan. That was sort of an older term. More recently, they coined the phrase moving into the 90s of the health span, and this was the portion of your life that was lived healthy. And now we've moved into the realm where we've included another phrase called the sex span, and this is just the portion of a couple's lives where they are sexually functioning. And so we'll kind of tie into that a little bit as we go through. First slide here, just to kind of highlight that, edcure.org. Great information. There's a QR code there, and then there's a video series link that everyone could take a look at. This is just good, well-rounded, accurate information with regards to erectile dysfunction, sexual dysfunction, and just good, reliable information there that everybody could take a look at their convenience. Looks like housekeeping items. So that's me there. I run our men's health clinic at the Urology Center here in Omaha. I finished medical school and residency around 2018, was later board certified by the American Board of Urology in 2020, and have been in practice ever since. My specialty, if you will, is in not only general urology, but specifically men's health, andrology, erectile dysfunction, testosterone deficiency. Those items make up probably the bulk of my practice at this point. So that's me. So we'll learn a little bit about erectile dysfunction. This can mean different things to different individuals. When we talk about erectile dysfunction, what most guys are referring to is hardness. So it's that ability to achieve and maintain an erection that's satisfactory for intercourse. But you could broaden that definition, which can include ejaculatory dysfunction, disorders of sexual desire and testosterone deficiency, orgasmic dysfunction. All of these things will sort of fall under that heading, if you will. The focus tonight is more on the traditional definition, which is what I would just describe to guys, couples as the hardness factor, and what we can do to help with that. Very common condition. It's not fair to say that that's normal, but it is common. North of 20 years old, it's probably about 20% now. And then over 40, we're looking at about half of men. And we'll talk about maybe why that is and some of the things that lend to that prevalence today. I'm going to move one of my screens here, sorry. So we'll talk a little bit about the erection process. What is that? How does it occur? And this is kind of the cornerstone for when we talk about all the treatments that are available. So when you look at a cross-section of the penis, you see these two large, what we call cavernosal bodies. These are spongy areas of tissue that receive blood from two central arteries or large blood vessels in the penis. And you need two things. One is you need to get blood into the penis via those arteries, and then you need to trap that blood there. And for most men, not all, but most men, there's some disruption in that process. where we're not getting enough blood in, or maybe we're not trapping that blood sufficiently. You have to be able to trap that blood there to get a good, hard, rigid erection. I usually use the example of a bicycle inner tube, which works pretty well. You can imagine you have to maintain that air within the tire, obviously, to maintain that rigidity. But another way you could look at that is if you had a small hole in that bicycle tire, you would want the airflow into the tire greater than the outflow, and that would help maintain rigidity. And that's sort of what we're dealing with the penis. That blood flow in is trapped there, and that maintains the rigidity that we know of as a hard erection that's satisfactory for intercourse. And this, unfortunately, tends to be the problem for many men. So we're going to talk about kind of what we do about this. So what causes erectile dysfunction? This is a list that most people are probably fairly familiar with in today's day and age. These are, what we would refer to medically as metabolic risk factors. These are conditions such as smoking, diabetes, high cholesterol, high blood pressure, obesity. These are conditions, if you will, that are hard on our blood vessels. We know that the erection, in part, is a blood vessel problem, or a blood vessel phenomenon, if you will. And when you have a blood vessel problem, this is going to affect our erections. But I'd also go on to say that erections are 10% mechanics, but 90% brain. So you'll see depression, psychological factors there. So these are real important as causative problems for erectile dysfunction. So common conditions that we would see: diabetes, other vascular issues or vasculopathies, peripheral vascular disease. These are folks that have trouble with the blood vessels, maybe in their legs or in their heart. Medication issues. So today, many folks are on a number of different medications, which can be implicated in erectile dysfunction. Urologic surgery. So these are things that potentially, we would be involved with, or sort of caused, if you will, maybe prostate removal or prostate cancer treatment, or even treatment for some other pelvic process. These are all various causes of erectile dysfunction. But I would always go on to say that it's never one thing. It's always a multitude of factors that collectively probably are the true cause of a man's erectile issues. Psychological effects. So this is very, very common. We see this on a daily basis. Guys get into this almost vicious cycle where they have trouble with the erections. They can get anxious about this. They can become depressed, low self-confidence. And going back to the idea that it's 90% brain, 10% mechanics, this is a huge thing, because as you can imagine, it becomes a vicious cycle where there's some worry about that quality of the erection. Well, that worry in and of itself can make things worse. And so, the psychological impact of this disease process is definitely real. We'll talk a little bit about diabetes. So, increasingly common in the United States. Most important statistics there is about 50%. So 50% or greater of diabetics are going to have some trouble with their erections. Why is that? Diabetes by nature is a vascular disease. In particular, it's a small vessel vascular disease. And unfortunately, we're not used to sort of appreciating what processes in our body are going on because of the health of our vessels. For example, heart disease may not be apparent until it's very significant. You take eye disease, or disease of the retina. Again, these are problems that may not necessarily become apparent until that disease process becomes more significant. These are common in diabetics. Well, erectile dysfunction, as we talked about, is also a vascular event, but this is one of the first things that guys are going to tend to notice. hey, I'm having trouble with my erections. Why is this? Well, as it degrades the quality of those blood vessels, we're going to see some degree of erectile dysfunction in at least half of those men. So we sort of talked about a little bit of this. It really is, diabetes by nature is a small vessel disease. And when you attack the small blood vessels, not only do you attack the blood flow component, that's, the component that is filling out the erection, but also the nerves that supply the erection. So you really need the parasympathetic nervous system to drive the dilation of those blood vessels. And so now the diabetics are getting attacked sort of in two prongs. One is we've got vascular insufficiency, the blood flow into the penis, but then we're also losing some support on the nerve side that's driving vasodilation, because the small blood vessels are supplying those small nerves. And so this is part of the reason why erectile dysfunction within the diabetic population is so common. I didn't really mention this on the previous slide, but there was mention to, why do pills not work so well in some or many diabetics? Well, the pills, take your Viagra or Cialis or generic versions of those, they're really designed to promote vasodilation through the nerve process. But the problem is, if the blood vessel is of poor quality, we may not see great results with the oral medications. And so this is one of the reasons why diabetics tend to struggle even with oral medications, at least later in the disease process. What are the other factors at play? Certainly age plays a role here. So the longer you're affected by diabetes, the more vascular damage there is. Potentially, as that disease goes on, we have more medicines at play. So this idea of multiple medications and interactions, et cetera, that can be a factor. Long-term effects of the blood sugars on the vessels, and then heart health. The diabetes, really puts a strain on the circulatory system as a whole. And so without a pump, if you will, the heart at its full potential, that's going to affect things too. So there's lots of factors with regards to diabetes and erectile dysfunction. This kind of ties into this. So we look at heart disease. Definitely has become I guess I shouldn't say a hot topic, but definitely it gets more attention now than ever. There have been some recent studies that have looked at erectile dysfunction as a sort of heralding symptom, if you will, of underlying heart disease. And we see today that more and more cardiologists trying to advocate for patients in primary care settings and just the general public that, hey, erectile dysfunction is a very common presenting condition that may suggest some risk of heart disease. And the statistics are fairly astounding. So you see that 70% of individuals that have some cardiac event probably had some degree of erectile dysfunction, not months, but years before their cardiovascular disease was diagnosed. So this slide illustrates sort of a simple fact, but it's good to highlight. When you look at the penile arteries there on the left side of the screen, you see the penile arteries. So these are the blood vessels that are going to supply blood to the penis. We're talking about 1 to 2 millimeter vessels. So these are very small. We can see these on a Doppler penile ultrasound, but you can imagine when you compare that to, say, the internal carotid, these are the arteries in the neck that some folks ultimately will have operations on to clear plaque or deposits in those vessels. So when you look at the difference in diameter, it's not surprising that you may see the effects on the penile arteries years and years before you're going to see those either in the heart or the internal carotids. So we'd love to reduce risk. This is a very important slide, and this is really what is going to promote everyone's sex span over time, is trying to reduce cardiovascular risk. This is the stuff that probably all of us are should be doing. It's easy to talk about, but sometimes hard to do. But healthy diet, exercise, decreasing weight. These are all factors that are going to decrease cardiac risk. And by decreasing cardiac risk, we're going to promote healthier vessels and hopefully prevent erectile decline over time. Low testosterone. So very common question today, where does testosterone play into erectile dysfunction? I would start by saying, I really believe, again, erections, it's sort of 10% mechanics, it's 90% brain. The testosterone piece is very important in the brain component because the androgen hormone really fuels the sex drive. But early studies on low testosterone did illustrate that guys that had low testosterone were more likely to have erectile problems. And that really is probably multifactorial. And when you normalize the blood testosterone level, those men do have better erections. They respond to the medications better, and their sexual functioning just overall is improved. Who's affected by low testosterone? They tend to be older, although you could probably argue that both ways. And again, just like erectile dysfunction, it's not fair to say that if you're older, it's normal to have a low testosterone, but it is more common. Other conditions that are going to increase your risk of low testosterone: obesity, again, diabetes, sleep apnea, HIV, many chronic medical conditions, medications. And then I would probably add to that, in the United States at least, diet, lifestyle, environmental factors are all changing the testosterone trend for men in the US and globally, really. So kind of touched on some of these. Low testosterone, reduced sex drive, that's probably one of the bigger ones. Erectile dysfunction, certainly. Hot flashes, body fat deposition. Some of these symptoms are sort of non-specific, so we really have to drill down on some of this a little bit more. But these are all the symptoms that we would see, with lower testosterone levels in males. What are the options? Thankfully, this is something that's easy to treat. We can give testosterone back. It can be in a number of formulations, it can be injections in muscle, patches. There are pills on the market now, which is relatively newer over the last couple of years. So it's much easier to give that testosterone back. We know now from some of the newer studies, that this seems to be decreasing cardiac risk in some populations, improving quality of life, certainly improving the sex span for men, but probably just improving overall lifestyle and lifespan for most men if they truly have low testosterone. So prostate cancer treatment. So, we as urologists, we're familiar with this population of men as we, offer prostate cancer treatment. Some of the information here kind of focuses on radical prostatectomy, which I think classically is what most guys know. It has some association with erectile dysfunction. Thankfully, as technology, surgical treatment technique improves, this is becoming a little less common, but certainly those men are out there and greatly affected by erectile dysfunction, partially as a consequence of their prostate cancer treatment. Today, we offer nerve-sparing procedures where we try to spare some of that nerve tissue or all of that nerve tissue that lies sort of in the neighborhood of the prostate. And again, this has gotten better, probably in the last decade, where we have done better on maintaining erectile function for guys with prostate cancer, but still can become an issue depending on a lot of factors. Thankfully, whether it's a metabolic problem or prostate cancer, these are all treatable conditions for guys that want to remain sexually active. So this slide just kind of briefly illustrates the idea of radical prostatectomy, although there's other treatments for prostate cancer that can have similar effects on the erections, but you see that prostate there that's circled in blue. So the nerve tissue, those parasympathetic and sympathetic fibers that sort of control much of the erection, unfortunately lie in that neighborhood. So there are times where they're just innocent bystanders to the treatment of prostate cancer. So you'll see those statistics there. Know your treatment options when you're talking about prostate cancer. We also want you to know your treatment options with regards to erectile dysfunction. But most of us would tell guys, on a general level, it's probably 50% of men that are going to go through some radical treatment for prostate cancer. They're going to have some trouble with their erections. It's important to highlight that does not mean that these men are not sexually functioning. It just means that we need to offer some treatment or potentially some more aggressive treatment to get them sexually functioning again. It's a slow process. So even with the nerve-sparing prostatectomy today, that recovery, if you will, from that operation, nerve regrowth, it's generally a year or more process. So, guys are still going to have trouble for that first, 12 months, even in the best of scenarios, but they're all sexually functioning if they want to be. We'll talk briefly about Peyrronie's disease. So guys out there in the audience may or may not be familiar with that. So Peyrronie's disease has gotten more popular media probably today than ever. Part of that has to do with some of the newer treatments that have come to market. So that has raised awareness for this condition. But Peyrronie's disease, by definition, is curvature of the erection, specifically curvature of the erection that maybe precludes or interferes with sexual function. It's not cancerous. It's benign. It's not going to affect anybody's lifespan, but certainly affects your sex span. And so we'll talk a little bit about that. So Peyrronie's disease is it's a fibrous scar that's deposited on the tissue of the penis. So if we go back to that inner tube idea, going back to that inner tube idea, you could think of it as a deposition of scar. It's an inelastic area that's deposited there that lends to that curvature, excuse me. Very treatable. So the next slide kind of highlights some of the things that are out there. Oral medications, these have been looked at for a long time. Fairly limited effectiveness, but they do exist. There are injectable options, drugs such as Xiaflex. These are injectable medications that dissolve that plaque. There's surgery to remove that plaque and straighten the penis. When we talk about Peyrronie's disease, I would sort of describe this in two realms. One is the quality of the erection. That's the hardness. In my world, I would talk about the hardness factor. And then the second thing is that curvature or the anatomy, the morphology, what is the curve? Does it get in the way of your erections? And guys that maybe have significant difficulty with the quality or hardness of their erections, they may benefit from penile implants, or more aggressive treatment options for erectile dysfunction, just because we know the more manipulation we do of that tissue to straighten the penis, we may have more of an impact on the quality or the hardness of the erection. And again, these guys are very treatable. It's just a matter of getting all the pieces together and making a good treatment plan and trying to recommend, the right thing for guys, depending on what the curvature looks like and what the quality or hardness of that erection is. Where does penile implant fall? Essentially, what this comes down to is again, it's that quality piece. Where does the quality of the erection stand? The more we do to fix the Peyrronie's disease, the more impact potentially we can have on the hardness of the erection. And so oftentimes when we're looking at correcting Peyrronie's disease, we dovetail that conversation into how are we treating the erectile dysfunction, because those two really do go hand in hand. And we'll talk a little bit more about that later, but that's where the penile implant for some of these men, certainly becomes an effective treatment option. So what are the treatment options? A little bit of that depends on who you're talking to, and rightfully, most men, they're starting with their family doctors and internal medicine physicians, which is great because, they're sort of on the front lines. They understand your medical history. They understand all your medications, and they know this disease pretty well, and they're screening for all those underlying cardiovascular risk factors and diabetes. And so that conversation a lot of times starts there. Many times you're referred to folks like myself and John, who, we specialize in these types of things, and can kind of help guide some of that advice or narrow down sort of what are the right options. And then there are prosthetic urologists. Again, these are surgeons like myself, John, Dr. Davies, who I think is giving a presentation in a couple of days, all of us that are familiar with putting in prosthetics to really help guys that are in that severe, if you will, severe erectile dysfunction category. But all of us are able to help with this discussion. All right, so what are the treatment options? Most guys are familiar with probably some of these, certainly the oral medications. These are your Viagra and Cialises of the world, and Levitra, Stendra. Now, these are on the generic market, so they've, we see more direct to patient advertising, online help with these. The oral medications are designed to promote dilation of the blood vessels. And so this is that idea, getting more blood flow to the penis. If you get more blood flow there, you're going to get more rigidity, but you need to be able to trap that blood there. On the whole, these medications are fairly effective depending on what population we're looking at. Thankfully, they've gotten much less expensive today, so guys are always surprised. And we typically try to start there. As urologists, the majority of the population that we see, tend to have probably tried and failed some of these at some point. Vacuum erection devices is kind of the second, sort of the second string there. This is probably something that guys haven't heard a whole lot about, but these are basic at the onset, so they're designed to pull blood into the penis. That's that blood flow in component, and then they're designed to trap that blood there. And so in that bottom picture there, you see a rubber band that's designed to sort of roll off of the device and provide some occlusion to trap the blood in the penis. Probably on a practical level, more of a love-hate for a lot of guys. There's a population of men that really do well with this, and they love these devices and they work very well. But there are also guys that and maybe hate's not the right word, but it just doesn't function well for them, either discomfort or they don't like the rubber band, or there's a lot of different reasons, but they are effective. They're readily available. There's no medication, so we don't have to worry about interactions with other drugs. They're easy to get. They're safe to use. So it's another option that probably isn't talked about as much as certainly the pills are. Intracavernosal injection. So this is another probably more common treatment for a urologist to offer, although primary care doctors will offer this as well. So these are drugs that are vasodilators. So they're designed to dilate blood vessels, just like the Viagra or the Cialis. But these are given via a needle as an injection into the penis. The benefit here is that the percentage of patients that respond to these tends to be a little bit higher. So overall, that success rate's probably 70 or 80%, all told. They are very effective. They're more effective than what pills are going to be because they're more potent. One of the benefits here is that they're not what we would call systemic treatment. So this isn't something that is going to circulate through your whole body, but rather it's given as an injection locally. So sometimes that can be an advantage, depending on medications and side effects of the medication. But you can't have some pain with these. Does have to be dispensed by a compounding pharmacy. So you can't just go to any pharmacy to source this medication. And then there's the injection process, which sort of goes without saying. It's not uncommon to get that kind of deer in headlights look when you start to talk about this. But the reality is guys do really well with these injections. They don't have a whole lot of pain with the injection. It's easy to use. It's easy to get the medication. So this is a nice starting point for a lot of men that have failed oral medications that we can look at, which is commonly known as trimix. Maybe guys have heard that term, TRIMIX, is sort of a trade name for those that class of medications. So what do you do when you've failed pills, vacuum erection devices, injectable options? This is where this does get fairly specific. In our world, we look to penile implants. So these are a mechanical device, if you will. This is surgically placed into the penis and is providing that rigidity just in a mechanical form. The benefits here, it's spontaneous. So you turn the device on when you want it, you turn it off when you don't want it. There's no pills, there's no injections. It's always in place. So that's one of the biggest factors that guys this appeals to, is that they have that spontaneous component where they don't have to fuss with the other things. It's obvious you're taking a bigger step on the outset. It is surgically placed, but guys do really well. We'll talk a little bit about that. Most common problems with these would be postoperative pain, which typically is resolving fairly rapidly. Infection, thankfully, those rates are pretty low, but that is something that we worry about when we place any prosthetic, whether it be this or a hip or a knee. We always worry about that. Mechanical malfunction, maybe failure or leakage of the device, because it does run on water, saline technically, but and again, those rates in today's day and age are very low. And then there's really uncommon complications like erosion, where the device wants to work through the skin or something for some reason. And again, these are things that we try to mitigate all these risks, but they do exist. But when you look at the guys that go through penile implant, the statistics speak for themselves. The vast majority, 95 to 90% of guys, would tell you, hey, I would recommend this again. This achieves what I was looking for, to maintain, spontaneous, reliable erectile function without the use of some of those other things. So Boston Scientific, they make a number of implants. The first two implants that you see there, this is a recent evolution of that inflatable three-piece device. So when I talk about inflatable devices, that's that AMS 700. Recently, we've seen a revision of the pump, which is that kind of grenade looking, I guess, device you see there. They've revised the pump a little bit to try to make that a little bit more user friendly. And then there's the Tactra, which is a malleable prosthesis. The big difference between these devices there is that the inflatable device, it runs on saline, and you activate and deactivate, or however you want to describe it, turn it on and turn it off. So you're moving water saline into that device to provide the rigidity. But then when you don't want to use the device, you pull the saline out of it, and it's all enclosed, but and brings the penis back to sort of that flaccid state. For some men, it makes more sense to have the rigidity all the time and just kind of maintain the directionality, if you will. So if you think of I usually describe the handle on like a microphone stand that is sort of, you can control the direction, but it always has that rigidity to it. Well, that's the Tactra penile prosthesis. And you sort of bend that in the direction that you want, but you always have that rigidity of the shaft of the penis. Less moving parts. It's right for certain men that we would kind of talked about and help guide that discussion. But those are the penile implants that are commercially available in today's market. That AMS 700, I would say that's what we implant the majority of the time. It just works so well. The satisfaction rates are so high, and patient satisfaction rates are high, but the partner satisfaction rates are very, very high, like north of 97%. Because what does it do? It provides that rigidity when it's inflated, and it's natural in appearance and feel when it's deflated. So again, it's all about, spontaneity, but then reliability. Guys don't have to worry about, hey, is the pill going to work today? Is the shot going to work today? Can I travel with this? Do I need to refrigerate my medications and things? And so, those are some of the selling points, for guys that are looking for something that is, more spontaneous and reliable. And guys ask this a lot. Is this new? It's not. I mean, it's been around longer than I've been alive. I hate to say that out loud, but it's true. About 50 decades they've been implanting these devices, and they've been revised over the years, to provide a little bit, probably longevity and infection mitigation with it and bring those risks down to the rates that we have today. But on its fundamental basis, it's the same device that they've put in for decades. It's just really shown to be very reliable and effective. This is a great video, just kind of about a minute long, and highlights the device. So again, it's surgically implanted, so you don't see anything from the outside. The pump is situated in the scrotum. So there you see he's applying some pressure to the pump. The pump is just moving fluid from that reservoir into those cylinders. So the cylinders are placed within the penis. And then he pushes another button to move that fluid back into the reservoir that then puts everything back into the flaccid state. So what to expect? Guys commonly ask, hey, if I'm going to go through this operation, the approach to the actual surgery depends on who's doing it. I tend to make mine with two incisions, two little skin incisions, one above the penis and one on the belly. I think all of us in our practice do this in a fairly similar way, but depending on who you're seeing, they may offer you a different approach to that. It's generally done under a general anesthetic, so you're completely asleep. Most guys would go home the same day or certainly the next day. I would tell guys, you're slow for a week, meaning you're moving around and doing most things, but um, probably not quite everything. By week 2, you're really back to life as usual. And then by weeks 3 and 4, it really is totally life as usual. Um, Sexually functioning probably at 4 to 6 weeks, although I've seen guys do it at 2 weeks. I've seen guys take up to 8 weeks, but on average, I'd say that 6 week mark is pretty accurate, to get full use and training out of the device at that point. Cost, very common question. Unfortunately, a lot of times we turf this question and say, well, it depends on your insurance, but I can tell you in my experience, the majority of carriers actually really do cover much, if not all, of the cost of the device. Um, Thankfully, between Boston Scientific and our staff in our office, we help investigate and troubleshoot all that. So that way, you really have an idea of what that cost looks like, what the out-of-pocket expense is, because obviously this is a big decision, and um, those are questions that we want to answer, and so we help with that. Um, this is one testament just from one gentleman that has a prosthesis. I think that, myself and John and Judd, we could all, we could line up guys all day long that um, really would tell you that this has made a big difference in their life, and um, um, gives them their sex span back essentially. And the vast majority of the guys that go through an implant would tell you, God, I wish I would have done this 10 years ago. Um, and again, that edcure.org or edcure.com website has great information. This is accurate. It's, reviewed by, experts in the field, and doesn't just focus on penile implant, but goes through the breadth of treatment options that we have available today. So definitely worth looking at. I think we talked about this, but this just kind of summarizes some of those statistics that are out there. This is focusing again on that inflatable prosthesis that we saw the video on. But patients are very satisfied. Partners are very, very satisfied. Low infection rate, reliable. You don't have to mess with the medications and the pills and the shots. And, it's not right for everyone, but I think it really speaks to the idea that if there are men out there that are struggling with erectile dysfunction, regardless of cause, um, we get all of those men functioning again, um, one way or another. And that's what the penile implant essentially was developed for, was that population of men that unfortunately have failed or used all these other things, and they've worked for years, but they don't work anymore. And so now what do we do? And that's what this, the population that this really serves well. I didn't focus on risks a lot, just like any surgery. Unfortunately, there are things to consider, and we talk a lot about this in the office when we go through these, and we're, considering this as an option. We worry about infection and, migration or erosion of the device and mechanical issues. Thankfully, these are things that are, single digit, if not less than 1% risks. But definitely we want to talk about these before we look at these as a surgical option. Penile implant's not the only option, so we looked at a number of other things. Guys commonly will ask us questions about some of the off the beaten path things, if you will. These are maybe stem cells or platelet-rich plasma, shockwave treatments. These are all treatments that are currently being studied. They don't have excellent long-term data like some of the other things that we talked about tonight, but they certainly are out there. We always encourage guys to talk to us about it. We can give you our opinions and kind of look at, what is the current literature out there that says, are these things going to work for you? Is it worth maybe some of the money that could, or, maybe should be invested in some of these treatments? And again, that edcure.com, we refer a lot of guys to that website. It's great, accurate information, but we're always happy to field those questions.
All right. Thank you, Dr. Quarter. Such an informative presentation. And we did get quite a few questions that came in. And you know what? For the sake of time, I think we'll ask a couple and then we'll pass it over to Dr. Bishay. And for those of you who have additional questions, definitely reach out. We'll talk about at the end how you can find these two and make an appointment. But let me go ahead and kick it off with a question that I get a lot. Does an implant guarantee orgasm or ejaculation?
Yeah, great question. We're doctors, so we're sort of, not to be like an attorney, we hate to use the word guarantee. There are a lot of factors that go into that. But in general, I would say that a penile implant should not affect your orgasmic function or ejaculatory function really in any way. The penile implant or any of those treatments for that matter are designed to add rigidity, which is really their goal. But again, depending on the cause of your erectile dysfunction, we could use prostatectomy as an example. There are other factors that are going to affect ejaculatory or orgasmic function, but by definition, yeah, the implant shouldn't change that. You should have normal sensation, normal ejaculation, normal orgasm function, or at least as you know it now.
What about, is it common to have low testosterone after having a prostatectomy?
That's a great question. People ask that a lot. So the prostatectomy should not affect your testosterone level in any way. Again, the asterisk on that, depending on the type of treatment for prostate cancer you have, there can be components of what we would call androgen ablation or driving the testosterone down. It's not commonly associated with prostatectomy, but by definition, your prostate being removed won't have any bearing on your testosterone level.
Thank you. And the final question, someone had asked if there's anything you can do about erectile dysfunction without taking a pill. You talked about some of the other treatment options, right? Like a vacuum erection device, but anything else outside of the treatment options discussed that individuals can do?
Yeah, it's a great question. I think, the short answer, yes, there's a lot of options available for guys that don't want to take pills. For the guys that we're seeing in practice, they maybe don't want to take pills, or maybe they can't take pills. It might be a medication interaction. It might be a side effect of the medication. And so that's where we look to some of those other treatments, such as the injections, implants, certainly, vacuum erection devices. So depending on what, maybe side effect, what risk we're trying to mitigate, there are these other options that we would look to, besides pills. I think pills are what most guys are most familiar with, but there's all these things that, that we like to talk to guys about.
Well, thank you, Dr. Quarter, for your expertise and your passion around this subject. And then for those of you who don't know, probably do, since you registered for the event, we're going to move on to talk about urinary incontinence with Dr. Bishay. So with that, I'll kick it over to you, Dr. Bishay. Welcome, and we're so excited to hear from you.
Thanks, guys.
All right, thanks for having me. Thanks, Dr. Quarter, for that well-informed presentation. Dr. Quarter's presentation is a more all-comers. It applies to many men, whether they've had a operation for prostate cancer or they just have what we would call organic erectile dysfunction. As we move into incontinence, this is going to really be specific to men who have had a prostatectomy and are now having issues with being able to control their urine stream. Again, thanks for having me, and we'll get started here. Here's some of my information if you're interested in my background. Next slide, please. So male stress incontinence. So a little information behind it. This is when guys can't hold their urine back. So strong Valsalva, such as lifting something heavy, laughing, sneezing, coughing, will trigger them to leak. Activity will trigger them to leak. Worldwide, there's about 13 million men who suffer from stress urinary incontinence. Most of this is all surgically induced. Annually in the United States, there's about 17,000 new men who develop it each year. So, obviously the process of being able to store your urine, your bladder is the storage unit. Your urethra is where your urine is going to exit, and your sphincter muscle is what can control and hold back your urine. And this is what we most commonly think of when we're actively stopping a urination. And when those muscles contract, the urine stays in the bladder, and when the sphincter relaxes, we're then able to go to the bathroom. The most common cause of stress urinary incontinence in men is the removal of the prostate, or a prostatectomy. And this is usually a cancer procedure for patients who have been diagnosed with prostate cancer. There are other causes such as BPH procedures. And then more rare causes are going to be neurogenic conditions, other pelvic surgeries, and urethral surgery. But stress urinary incontinence really does affect the quality of life of our patients. A lot of guys really want to get their erections back, but most of them don't want to get their erections back if they have bad stress urinary incontinence. A lot of them will say, well, I want to get this fixed first. We can do them together as a side note, but most guys, if they're suffering from stress urinary incontinence, they do want their incontinence fixed before they really feel like they can get back into the game and have a good sex life. Next slide. So stress urinary incontinence and prostate cancer, like we said, most of these patients are prostatectomy patients. There's about 90,000 radical prostatectomies done in the United States every year, and 9% have persistent leakage. I don't like that stat that goes up to 16, but I think in most experienced hands, it's around 9 to 10%. The last study I read, the last study that I read, had 91% continence recovery and 9% persistent incontinence. And so those are the men that we're targeting tonight. So you can see the prostate again. You've seen this diagram tonight. When we remove the prostate, we remove a significant portion of the anatomy that provides some resistance to keep your urine stored in the bladder. So when that's removed, we then have to train the pelvic floor muscles to or take over what the prostate was helping in being able to store your urine. So your treatment options. One, obviously, we always work on behavioral changes and lifestyle changes. So behaviorally, some patients will drink less fluids, but we don't really love that. We want them to stay hydrated. But time voiding is also a good one. So making sure that you go to the bathroom often on the clock and not waiting until your bladder is significantly full and then you can't hold on to that amount of volume. And we send everybody to pelvic floor physical therapy. We teach them how to do Kegel exercises. We do a lot of biofeedback with our physical therapists, and we really try to get the muscles to strengthen, because men know nothing about their pelvic floor muscles or Kegel exercises until they are in need of a prostatectomy. But women who use their pelvic floor muscles all the time are much more in tune with that. So we got to teach our patients how to get control of those muscles. Men who are coping with this, obviously pads, diapers, catheters, or a penile clamp are some of the easy things we can do, but nobody wants to leak urine. So that's why that's what we're here to talk about tonight. So the first thing that we're going to talk about for stress urinary incontinence treatment is going to be the Advanced XP Male Sling System. So this is used to treat mild to moderate stress urinary incontinence. And the way I kind of divide these out, there's a lot of different ways. There's a lot of guys that get into this really pretty academically and scientifically. But ultimately, if you're kind of having some incontinence, meaning that you wear 1 to 2 pads a day, but they're not super soaked, and you're able to control your urine still, but this is annoying to you, then the sling is for you. Okay. And it's to treat mild to moderate stress urinary incontinence. It is a minimally invasive procedure. It works on its own. You don't have to manipulate it. Once it's in, and it's going to stay there. The study that we still quote reported a reduction in pads by 77% in men who underwent a sling. But the key to a sling is you got to make sure that your urologist is evaluating you appropriately and understanding how much incontinence you're actually having. And so you want to be really, you want to be accurate when you're explaining to your urologist how much leakage you're actually having throughout the day. So the way it works is it acts as a hammock. It's supporting the urethra. It's putting some extra pressure there to provide resistance, so that the urine can be held back. And 88% of patients surveyed recommended the sling to a friend. So people were really, really pleased with the results that they got out of after having a sling. So your other option, if you have much more stress urinary incontinence, is the artificial urinary sphincter. This is the gold standard for treatment for men who have moderate to severe urinary incontinence. And the system was really designed to treat all levels of incontinence. But if you're soaking through pads and wearing more than 2 a day, this is really what you want to go for. It's still discreet. It feels natural. Nobody can tell that you have one in, and it mimics the function of a healthy sphincter, meaning that when you need your sphincter closed, it's closed, and then when you're ready to go to the bathroom, you go to the bathroom and you activate it, and you're able to go as normal. The one thing that it requires is you got to have good cognitive ability. You got to be able to know when and how to use it, and then you got to have good manual dexterity, meaning your hands have to be able to run the device to be able to use the restroom. So this is the artificial sphincter itself. It's a little bit more involved than a sling. It's got a cuff that goes around the urethra and a button that's sitting underneath the skin of the scrotum, and then a reservoir that holds our fluid, and it's pressure regulated so that when you push the button and your cuff opens, that drives fluid from the cuff and into the reservoir. And then over about 1 to 2 minutes, depending on the size of the cuff, that fluid will slowly circulate back to the cuff so that your urethra will be closed. And here's a little video of that process. It's very similar to the functionality of a inflatable penile prosthesis in the means of the activation device is in the scrotum, right underneath the skin of the scrotum. When you're ready to go to the bathroom, you push your pump, and you only have to push it once. And make it completely flat. Once that happens, the fluid goes out of the cuff and into the reservoir, allowing you to urinate, and then it closes on its own. You don't have to worry about closing it. So typically it's an outpatient procedure. It's one incision underneath the scrotum, and then a tinier one up near the abdomen to put the reservoir in. And usually men are able to return back to non-strenuous activity in a few days. And then we usually wait about 4 to 6 weeks before we turn it on so that all the swelling can go down and you're able to manipulate the pump well. So people, this is one of the procedures that I do that almost every man is absolutely thrilled that they did it after they did it. They always say, "Doc, I waited 2 or 3 years. You kept telling me that I should do this, and now that I've done it, I wish I did it 2 or 3 years ago." 90% of surveyed patients will report long-term satisfaction. More than 90% of patients would do it again, and 94% of patients would recommend it to a friend. And then long-term studies show that 85% of patients um, at nearly 4 years weren't using pads. 96% of patients at 6 years, and 90% of patients at 5 years. These are multiple different studies, but this is a really high success rate when it comes to a surgical procedure like this. So cost and coverage. This is usually covered by Medicare. I've never had any issues there, and most private insurances. Coverage varies. So again, our office has a whole team of people that can help you get this covered if this is something you're interested in. And typically we usually don't have any issues in this realm of incontinence. There's many testimonials that you'll find. Again, there's not very many procedures that guys are just super thrilled that they had after they did it. But here, Herschel, he says it took me from 9 pads a day to 1. I wear 1 pad because I like to laugh. It makes me feel like I can do things I want to do with the confidence of not having to worry if I wet on myself or not. And this is a really huge game changer from a quality of life standpoint. So, our goal with both these procedures is to achieve bladder control, able to urinate when you want, and not have to worry about the pads being soaked through. It's completely unnoticeable to the naked eye. Only you know it, and any significant partners. You got high patient satisfaction, and it restores your quality of life. The risks, just like everything else, like Dr. Corder discussed, you can have device failure. This is a mechanical device, so it can fail over time. You can have acute urinary retention or postoperative pain, and then irritation at the wound site. Infection is obviously something we worry about in any implantable device, but really with the inhibizone, and then also using modern antibiotics preoperatively and postoperatively, those risks are all down to about 1%. With device malfunction, we can always replace the device if we need to, and this is one procedure that guys are always ready to get it replaced when it needs to be done, because they're so happy when it works. Erosion of the urethra is rare but can happen, and again, whenever something like that happens, that doesn't mean you can't get another one. We just have to work through that process. So fixincontinence.com is a great place to go get information about this. I know it's not as sexy as erectile dysfunction and getting that sex life back, but most men don't want to get their sex life back until they get their urinary control back. And so this is a great website